So earlier, Dr. Arai, in his introduction, challenged us to push the boundaries of Angio CT. So our next speaker, Dr. Farah Irani, is going to take on that challenge and share with us how she is going to do that. Dr. Irani is a senior consultant at the Singapore General Hospital. Farah?
Thank you very much. Good evening, ladies and gentlemen, and I'll be speaking to you on the hybrid angiography CT systems pushing the boundaries. I have no conflict of interest, so any disclosure. I wish this slide was not filled with that machine, but with lots of consultant. But unfortunately not. This is one of our systems that we have in our department, which is a CT scanner combined with a fixed fluoroscopy machine. This is the newest one which we have, which is the Prime CT, which is a 160 slice scanner. So image-guided interventional procedures using the Angio CT was first came into force in 1992 and was developed in Japan by the gentleman sitting right in the front, Professor Arai. We had our first machine installed in 2008, and we had our second machine installed in 2016. So the Angio CT basically consists of a CT scanner and an angiographic system, which are placed in the same room, and they share the same floating tabletop. They're used either in conjunction or they can be used independently. So you don't need to use both the systems at the same time. And that gives the room a great deal of versatility. So you can always use the scanner whenever you think you require it. The session is quite interesting, and I'm actually going to go and bring everybody's adrenaline down. We're not going to go into the trauma suite. We're not going to see all that high-level kind of exquisite resuscitation. So there are only going to be two topics I will speak on where we will push the boundaries. And the first one is actually a pilot study that we performed for the study of intra-arterial low-dose contrast CT perfusion of the foot before and after lower limb revascularization. And we wanted to see whether it's technically feasible and what would be the outcomes. And the gentlemen who are listed below were all involved with this study. And I'd like to thank them for their contributions. So what is the problem of peripheral vascular disease in Singapore? It's very highly prevalent. It has a prevalence of about 8%. The majority of patients actually present quite late, and they generally present with CLI. They generally present with foot ulcers and gangrenes. That means they're Rutherford 5 and 6, where their legs are almost dropping off. Claudicants in our population are extremely rare, and we have a very high incidence of infrapopliteal disease. So if you look at this diagram, which was actually performed, we find that only about 3% of our population have aortoiliac disease. 25% of them will have femoropopliteal disease, but almost 75% of them will have disease below the knee and involving disease below the ankle. So you see that our disease is very, very peripheral, and that makes revascularization quite difficult. We also have a very high incidence of diabetes as well as ESRF, and our diabetic population is almost 8.2% of the general population. So this tsunami of diabetics is coming our way, and therefore we need to up our game to decide how we can save patients' legs. Endovascular revascularization of the BTK vessels, actually, we're quite good at it. We have a very high technical success rate of almost 88 to 89%. But in spite of that, we have a very high limb loss of almost 20%, where almost 20% of these patients will lose their limb at some point and have a below knee or an above knee amputation. The other thing that you must remember is that if the patient loses his leg, his cumulative death or his cumulative mortality per year would be almost about 20%. And that is why it's very essential that we save patients' legs. They also have other comorbidities in the terms of the heart disease, which make them very, very brittle and very, very highly difficult patients to treat. So this will be the various wounds that you will see for patients who have chronic limb ischemia. And therefore, wound healing becomes very important. Wound healing is actually a very dynamic and a very complex process. It gets impaired when you have presence of hyperglycemia, chronic inflammation, micro or macro circulatory dysfunction, hypoxia, as well as neuropathy. So just by opening up the vessels does not indicate that the wound will heal. The treatment is always very multi-dimensional. You need to have debridement, you need to have pressure offloading, you need revascularization, and you need infection control. The macrovascular circulation is always assessed, can be assessed either with 2D DSA, that's angiography, it can be assessed with CTA as well as with MRA. But the microvascular circulation, which is actually very, very important for wound healing, is quite nebulous. And the way you can actually assess that is either by transcutaneous oxygen tension, hyperspectral imaging, laser Doppler, or indocyanine green angiography. But these are not really well established. And therefore, within this big group of tests that you can do, we're trying to introduce what is known as CT perfusion. So there are a few studies which have come out in the recent literature which actually assess CT perfusion of the foot after revascularization. But what they do is that they actually look at IV CT, and that CT does not actually help you during your procedure. So the aim of our study, so perfusion imaging of the foot actually is very technically challenging because the foot in essence has a very reduced baseline blood flow as compared to the brain and solid organs. And because you have adjacent bone, which is very close, there's a lot of beam hardening artifact. And the other most important thing is that the foot moves even with non-intention tremors, and therefore the movement artifact can degrade the imaging quite a bit. So the aim of our study basically was to assess the feasibility of CT perfusion of the foot with an intra-arterial low-dose contrast injection at the time of endovascular revascularization. And we wanted to evaluate these changes in the perfusion after revascularization. So what we did was, this was a prospective single-center pilot study. It was locally funded by our institution. It had IRB approval, and every patient had to give written informed consent. All patients who had CLI were referred to our center, were screened for eligibility to enter this study, and CT perfusion was obtained both before as well as after the revascularization. So the inclusion criteria for the study was written informed consent, age more than 45 degrees, any patient who had either Rutherford 5 or 6 lesion, endovascularly treatable stenosis or occlusion of the crural vessels with or without treatable femoral and with treatable femoral and iliac stenosis or occlusions, and the patient had to have either one patent dorsalis pedis or plantar artery before treatment because we needed to develop the perfusion maps before we treated them. And these are all of the exclusion studies. So any patient who had acute thrombosis and required thrombolysis was excluded from the study. If they had aortic stenosis or occlusions, they too were excluded from the study. If the patient had an EGFR less than 45 mils per second, because we were using contrast, we then excluded those patients from the study because we were adding extra contrast to this patient group. But if they were ESRF and on dialysis, they were included into the study. And if they had uncorrectable thrombocytopenia or coagulation abnormalities, they too were excluded from the study. So this procedure was done in the hybrid CT angiography suite, which consists of a 160 slice scanner with a 4 centimeter volume. So if your slice volume increases, the z-axis of your perfusion will improve. It had a ceiling mounted flat panel DSA, and we had a single floating tabletop. So this was the machine that we utilized. So the contrast protocol was that every patient had an antegrade inserted 6 French sheath. We had a dual-headed pressure injector, which basically gave you a PSI of 325, and this, as you can see, you can change the contrast density as well as the pressures. We used the same protocol both for the pre-procedure as well as the perfusion scans both before and after the intervention. We used Visipic 270, and the concentration of contrast was only 40%. The total volume used per perfusion scan was only 12 mils, which made up to about only 4.8 mils of Visipic. So we're only increasing the total contrast load for this intervention by 10 mils. The rate was 4 mils per second and had a saline chase of 12 mils at 4 mils per second. And there was an injection delay of saline at 2 mils per second, and that we calculated from the DSA. So we had to develop this kind of locally generated foot restraint. So this kind of box helps the foot keep very still. It reduces the motion artifact. It keeps the foot dorsiflexed because you need to get the 8 millimeters so we could get maximum coverage in the z-axis during the perfusion. And therefore, this helped get us very good perfusion maps. The perfusion scan protocol, we had 2 phases for the perfusion. So the phase 1, we used the same kind of KVMA and the rotation times. But what we needed to do was we had a start time of 0 seconds to 33.3 seconds, and the acquisition interval was only 3.7 seconds in the phase 1. And therefore, the total time that we scanned phase 1 was this much. So we actually gave a lot more scans during the phase 1 part of the acquisition. The second phase of the acquisition interval was only 5 seconds, and its end time was 1.9 seconds, so it was just about 17.2 seconds as the second phase. So we had 10 scans in the first phase and 4 scans in the second phase. And we actually, because we had only a 4 centimeter acquisition, we had to use what was known as the jock. That means the CT scanner would move from one position to the second position so that we could get a total coverage of 8 seconds so that we can cover the entire foot. If you had the Aquilion 1, which is a much larger scanning volume, then you don't need the jock function and you can actually scan the entire foot with one perfusion scan. And we'll see why that is important. So then you come to what you do with that data that you accumulate. It's sent to the Vitrio workstation, and you can use what is known as a single arterial input using the upslope technique. So what you do is that you generate these maps, and you have this very complicated mathematical formula. And what you do is you draw an ROI on the vessel, which is patent, and in addition you draw an ROI on the tissue, and these two ROIs will then generate the blood flow map and the tissue perfusion map. So you need to find out what's the time to peak for your arteries. So this is an example of a patient. So he's a 65-year-old Chinese gentleman who had peripheral vascular disease with fifth toe gangrene. He had previous amputation of the first and the third ray for osteomyelitis. He had these significant comorbids of hypertension, diabetes, and ESRF with multiple access issues. And his toe pressure was only 455 on the right fourth toe and 76 on the left first toe. His Doppler scan showed multifocal stenosis in the ATA and in the PTA and with diffuse arterial calcification. So you can see that he's very clean in the femoropopliteal segment, but you can see that his infracrural vessels are significantly diseased. So if you just look at his infracrural disease, we can see we have significant steno-occlusive disease both in the ATA and the PTA, and actually the flow going down to the foot is patent by the dorsalis pedis and the posterior tibial artery and the lateral plantar arteries. So this is the pre-procedural perfusion scan. You can see that that's the time to peak. So this is the perfusion scan, and actually this is color-coded. So anything which is in the red and orange and red zone, this is warm, that means the perfusion is good, whereas anything in the blue and the green zone means perfusion is not very good. So you can see that most of the foot is actually quite underperfused and does not have very good perfusion. The other thing to note is that these two graphs that you have, this is the arterial input, that is the time to peak, and this is your tissue perfusion map, which was represented in the color map, which was shown. So this is the intervention we performed, whereby we recanalize both the ATA and the posterior tibial arteries, and you can see that there's straight line flow down to the foot with very good perfusion of the foot. And when you look at the perfusion map post-intervention, you can see that there's significantly more red and yellow colors which go into the foot as you get better perfusion going down. And the other thing to note is that the time to peak now becomes shorter, indicating that the flow rate is much better through the foot. So these are the two maps. This is pre and this is post. You can see that the pre time to peak is only 12.7 seconds, but after you do the intervention, this time to peak actually shifts to the left side, and your time to peak comes down to 8.5 seconds, indicating that you've improved the blood flow going down to the foot. So the blood flow maps can be calculated from the Vitrio station. You can draw these color maps, and you get what is known as arterial flow, which is measured in ml per minute per 100 grams. What you do is you measure this in the dermal hyperperfusion band, because you know that the muscles actually don't get as much blood flow as compared to the dermal hyperperfusion band. And what you do is that you draw ROIs in the dermal hyperperfusion band at the head and the base of the first and the fifth metatarsal, which incorporate both your dorsalis pedis and your plantar perfusions. So what are our results? This was the demographic data of our patients, where we had about, the mean age was 67.4 years. Most of them were males. We had a varying degree of ethnicity, and almost all of them had diabetes. One of them had cardiovascular disease. Coronary artery disease was seen in 9. Cerebrovascular disease was seen in 1. 5 patients had ESRF, and the number who smoked was quite low. So this is a very complex table which tells us which arteries we were able to recanalize, which we were not able to recanalize. And at the end of the intervention, in that cohort of 12 patients, 2 patients had single vessel runoff to the foot. In 7 patients, we had 2 vessel runoff to the foot, whereas in 3 patients, we had 3 vessel runoff to the foot. So you can see that we've at least managed to get 1 single vessel going down to the foot. Now, if you look at the contrast volume that we used, it was very minimal. It was only 9.6 mils for generation of 24 perfusion maps. The mean effective radiation dose was also very low at 0.145 millisievert. okay, because your effective ankle dose is very, very low. And when we look at the results, we were able to it is technically feasible to generate perfusion maps in all 24 perfusion scans that we tried to generate. We found that the time to peak reduced after revascularization with a p-value of 0.007. So you can see that in certain patients, we actually had the time to peak increase, and this is in patient 1 where we were unable to recanalize the artery, and hence the time to peak actually reduced. If you look at the arterial map, we found that after revascularization, the amount of blood going down to the foot had also increased with a p-value of 0.004. And there were some very interesting results. So if you look at the patient number 1 and patient number 11, in patient number 1 the amount of blood going down to the foot was 1,538, but post it was 708, because in this patient, when we tried to recanalize the anterior tibial artery, we actually dissected the artery and we lost the artery. So the perfusion map actually will reflect what the DSA shows. Patient 11 is very interesting. Even though he had a very good outcome whereby we were able to revascularize the big vessels going down to the leg, his foot actually, the perfusion post-intervention was very, very poor. And this patient actually had a BKA 2 months down the line. And this could tell us that actually, even though his macrovascular circulation was very good, his microvascular circulation, which actually determines wound healing, was actually very, very poor. So although you have very good macrovascular circulation, and that is the dichotomy of the situation you're in, because even though you open up the big vessels to the foot, it may not translate into limb salvage. So potentially, this technology can tell you to find out which patients will benefit or which patients would benefit from an earlier BKA rather than a later BKA. So the drawbacks of this study was that when you cover 8 centimeters using the jock function, you get a lot of loss of data because there is a definitive line which comes in and there is some loss of data that occurs. So that is the drawback of using a smaller foot plate. And the most important thing is that we have a very small sample size of only 12 patients. So in conclusion, we can state that the CT perfusion of the foot, it is technically feasible. You can obtain maps at very low contrast dose of 9.6 mils with a very low radiation dose to the patient, so you're not actually harming the patient in any way. But you require significantly more studies to actually understand and to take a note of what are the changes in flow dynamics in the foot post-intervention at the microvascular level. And this would be the thrust of further research, is actually to find out which patients will do well and which patients will not do well. And furthermore, it would also tell you when to terminate your intervention. That means if you open up one blood vessel and you get a very good post-perfusion scan, then you can actually just stop rather than try and open up multiple blood vessels. So with that, that's the end of the first part of the talk. I'll just quickly tell you something about volumetric embolization and volumetric CT. So this is just one case that we did. This is a 48-year-old Chinese gentleman who has Child's B9 liver cirrhosis with the genotype 3A-HCV. He's complicated by the presence of HCC, which was treated with TACE twice. He has portal hypertension and hypersplenism with varices. He is diuretic intolerant ascites, and he has hepatic encephalopathy. And in all that, in addition to that, he has pancytopenia with a platelet count which is very low, of only 17,000 to 48,000. But the most important thing is this gentleman is waiting on the liver transplant list, waiting for his transplant. And no surgeon is going to go in in a patient who has portal hypertension and varices with a very low platelet count to do a liver transplant. So initially, he was treated with L-Thrombopac, which is a drug which is given at 25 to 75 milligrams, and it actually helps raise the platelet count up so that this patient on the DDLT transplant list is when his turn comes, he can get the transplant, and he does not get the transplant because his platelet is not very good. However, he didn't do very well with L-Thrombopac, so he was sent to us for partial splenic embolization, which is basically the treatment for thrombocytopenia and hypersplenism in patients with liver cirrhosis. The mechanism of action is that it reduces platelet sequestration and allows the increased production of thrombopoietin, which will increase platelet count. Your aim of partial splenic embolization is basically only to embolize 50 to 70% of the total splenic volume. This procedure should not be taken lightly because it has a morbidity of about up to 17%. And you can read the morbidity can be post-embolization syndrome, splenic rupture, pneumonia, portal vein thrombosis, and gastric ulceration. And it has a mortality of 0 to 12%. So patients can die from your procedure. If you do get portal vein thrombosis in a patient who's on the transplant list, you get him off the transplant list. So you need to be very, very careful when you're doing this procedure for liver transplant patients. The importance is that the results will improve your platelet count up to twofold for up to a year. You get improved WBC count, and you also get improved liver function in the interim because you're diverting more blood to the liver rather than to the spleen. So this is the gentleman. He has a large spleen, as you can see, and his total splenic volume is 1,238. So if you have to take out 50% of the spleen, you can actually do something like this, whereby you can go into the anterior and posterior divisional artery. So this is the posterior divisional artery. You can do ICTA, and this way you can calculate the volume of each artery that perfuses different parts of the spleen. So you basically want to embolize the inferior portion of the spleen, not the superior portion, because that will lead to extensive pleural effusions. So this is the posterior inferior branch of the spleen, and you can see that the volume that we calculated was 398. So it's quite a large volume of the spleen, so we decided to embolize this artery. And then we went into the anterior superior branch. We saw that it was supplying some part of the peritoneum, so we coiled this branch, and then we went up, and then we did a volume over here. This is a splenunculus in the patient. So when we did the volume on this calculation, we found that it supplied 102 mils of the spleen. So 400 with another 100 is another 500. And then we went into the anterior inferior branch, and we found that that supplied another 136 mils of the spleen. So in total, we took away 650 mils of the spleen, which we thought was a significant amount of spleen that we could take, which was about 50% of the spleen. And you can see that the post-embolization, you can get this very patchy kind of enhancement of the spleen. And what we did is 2 weeks later, when we did the ultrasound, you can see that this is the normal perfused spleen, this is the infarcted spleen. But what you maintain is, when you take off only 50% of the spleen, is your portal vein, and the portal vein does remain patent. So you must be very careful when you're doing these patients, because you don't want the portal vein to thrombose. And if it does thrombose, you need to go in and quickly treat that. And then you can see that this is the level of intervention. These are his blood works. You can see that his platelet count is really, really low. It's usually about 33, 38. And after we did the intervention, you can see that the platelet count rises and it goes up to 145. And this is the spleen 6 months later. You can see that it has not had, although it's infarcted, it has not had any abscess formation. And over time, actually, the spleen will regenerate. And that is the reason why you need to treat these patients within the year after you do the partial splenic embolization. And with that, I thank you for your attention.
Okay, thank you, Farah. I think we have time for a couple of questions. Yes, Manish. Can you use the mic, please?
Farah, thank you for showing the perfusion imaging. So it was quite useful to see. I mean, it's a great job. Now, in real life, how does it help you to, say, like you said, you had a patient which had poor. So patient, suppose, came to you with an ulcer, and you have the angiosome concept and you improve everything. So how do you decide that, okay, this one's not going to do well? I mean, you say early BKA. I mean, how do you decide that? I mean, is it good enough to tell you all the data that you have?
No, actually,
First question.
Yes, sir.
Second is, how much is it better compared to an angiographic picture? Because there are multiple factors, say, compared to brain perfusion imaging, foot perfusion imaging is much more complex. You know, there's a multifocal disease. Brain perfusion is just one open artery you do before and after. So how much does it affect you in real life amongst the prognostic compared to a direct angiographic image?
So the thing is that if you look at direct angiography, it's mainly only looking at the macrovascular bed. You're just looking at the DP, but you're not looking at the microvascular bed. So the microvascular bed that is what is important for your perfusion, actual perfusion. So if your microvascular, so in diabetes, if you actually look at it, it basically affects the microvasculature. So there are studies which actually were initially done, which actually tell you that even though the macrovascular bed is okay, the microvascular bed is not okay. And that's why your foot will never heal. So in that situation, we just wanted to know whether perfusion imaging will actually help you to decide which are good players and which are bad players. Because at the end of the day, you still need to decide how much you're going to debride, and try and salvage that foot in that sense. This was just a technical feasibility study to assess what your end point would be. There's a lot of work that needs to be done, and I completely agree that foot perfusion actually is extremely complex because you have 3 blood vessels which are going in. There are multiple choke vessels within the foot. So actually, just by putting the ROI on one blood vessel and then generating the maps would actually be very different rather than generating 3 perfusion maps on 3 different blood vessels. So as we were doing this study, we actually realized that it's not just one blood vessel that you need to look at. So maybe going forward, we need to relook at this data and draw perfusion maps to each blood vessel that you actually intervene on. Yeah, because that actually changes the map.
That's what I'm saying. Injecting just in femoral artery doesn't help you. You need to have map for each.
Yeah, maybe we would need to think about that. So this was just a technical feasibility study to actually understand the basis for doing a perfusion study of the foot. And that's what we found out, that it's actually very highly complex.
Okay, one more question. If not, thank you. And we're going to invite Dr. Arai and Dr. Tay to come to chair the rest of the session for this evening.